little girl infant born to a primate, be a C-section because she was breech. So what is this kid at increased risk for? Just with that history. In an orthopedic lecture. Yep, developmental dysplasia of the hip. Absolutely. So that is either a dislocated or a dislocatable or subluxable femoral head. You will see it because it affects anywhere from 1 to 2% of all newborns. So, risk factors: female, breech, oligohydramnios, or family history. So the American Academy of Pediatrics recommends in their guidelines for screening for DDH that all newborns have a physical exam to check for this, and we'll go over how you do that. Breech newborns get an exam either with or without an ultrasound. So when you're on the inpatient service, if you see a baby who is, or especially a female, who's a breech presentation, you might think about ordering an ultrasound. Okay, and if you've seen us do it before, that's why. Females with a family history, absolutely, they need an ultrasound if it runs in the family, usually at 6 weeks of age, or plain films at 4 months. Your ultrasound is only sensitive before 4 months of age, and it's a dynamic ultrasound. It's not a static ultrasound, so they'll actually ultrasound while they're moving the femoral head. And then after that, you have to get plain films. If your exam is positive, you're done. You don't need to get an ultrasound. You don't need to get radiographs. You just call ortho. That's it. If the exam is equivocal, meaning you're not sure if you felt a clunk, then you re-examine them at the 2-week checkup. If it's positive, then you're done. You send them to ortho. If it's still equivocal, either send them to ortho for a second opinion or get your ultrasound. If it's negative, then you just keep following up. And you do need to be checking this in your physical exam at every well-child visit until 4 months of age. So what you're looking for on that is you need to look at the thigh folds and make sure they're symmetrical. You need to check that the child, either by asking or by watching the kid move, that they're moving both lower extremities symmetrically, that they're abducting both legs. The Galeazzi test, which I'll show in a minute. We'll go over the Barlow and the Ortolani test. Those are sensitive until 3 months of age. Okay. Dynamic ultrasound of the hips up to 4 months, radiographs of the hips after 4 months. So this is the Galeazzi test. So you lay the kid on their back and you put both heels on the table. And if they have DDH on one side, the femoral head will be dislocated posteriorly out of the socket. And so one knee will be significantly lower than the other. Okay. And the Ortolani test and the Barlow tests. Okay. And I never remember which is which. I just know which motions I have to do. Okay. So this one you're going to have to gather around for. Okay. All right. So first we'll do the Ortolani test. All right. So you flex baby's hip to 90 degrees, and you flex the knee to 90 degrees. Okay. And you grasp with your fingers behind the femoral head. Okay. And then you gently abduct the thigh out until you are parallel with the acetabulum. And so what you're feeling for, or what will cause a positive test, is if this femoral head is already dislocated, then when you move in this direction, you're reducing that femoral head back into the acetabulum. And so you will feel a clunk as that femoral head goes back into the acetabulum. Okay, so you don't need to be pushing down, you don't need to be grinding, you just kind of gently flex the hip and knee and bring it out to the side. Hard to do on a squirmy move, but you got to do. Okay, the other one, Barlow one, all right. Flex the hip, okay? Not as important if you flex the knee on this one. However, because you do have to kind of push down on this one, I find it helpful to also flex the knee on this one. This time, I'm grasping the thigh, okay? I'm pushing, this time I'm trying to dislocate the femoral head, okay? So I'm pushing directly posteriorly, so straight down, and then I'm abducting out because I'm trying to see if I can dislocate that femoral head by pushing posteriorly and abducting. And if I feel clunk while I'm doing that, that's positive. Call. Okay? Alright. These guys are up here to practice there. They don't have questions on that? Okay. So our other hip one was mom brought in a 10-year-old who's pretty active, and he was having some hip pain after he was active and has gradually started limping on that. So what are 2 things you're thinking about just what that is? Skiffy? Okay.
Leg calf hurt?
Yeah, absolutely. That's the other one. Okay. So skiffy is where the femoral head gets separated from the rest of the shaft of the femur. So you get a shearing off to the ipsial plate there. It's more common in the tweeners who are a little bit chubby, and it's more common in guys. The board question you'll always see is a lot of times it actually presents as anterior knee pain. So keep that one tucked away in the back of your head. The affected leg at rest is usually externally rotated, and the kid will usually keep the hip flexed because that's more comfortable. So if you see this, what are you going to do? Kid comes in, has some hip pain, you send him downstairs for x-ray, comes back up, you guys look at the x-rays together, you go, holy cow, that's a skiffy. The neck of his femur is way up here, and his femoral head's way down here.
Which x-rays do you get? Do you get like just a standard like right hip and frog leg x-ray? Is that what you ordered?
Yeah.
Okay.
So I get the affected hip, and then I get a bilateral frog leg, so I can compare to the other side. So I see that. What are you gonna do? Okay. So you're just gonna have the kid walk out the door and down the street toward them. Thank you. Yes, absolutely. Go downstairs, get the wheelchair. Okay. Just making sure. Okay.
It's a block that way.
I mean, I know it's not far, but no, that kid's not walking downstairs. Sorry. Okay. And then, I'm sorry.
Start hopping.
Right.
Really straighten that up.
All right. So this is compared to leg calf Chris disease, which is idiopathic osteonecrosis of the capital femoral head. This tends to be younger kids rather than the tweeners. They're limited in internal rotation of their affected hip. The x-ray shows a smaller ossified femoral head. And unlike emergent hitting by ortho, this one, they just have to sit in bed and play video games for a week, which they'll hate. If greater than 50% of the femoral head is already involved, then bracing may be required by ortho. So this is one of those things that you could probably feel pretty comfortable saying, hey, go home, be non-weight bearing and rest for a week. You'll probably be fine. Just in case, let's also have to see ortho. Just so we can get their blessing on it. Okay. And then uncommon things that you just always have to at least think about when the kid's in your office. Infection, either septic arthritis in that joint, discitis that's referring to the hip, osteomyelitis, myositis, OCD, tumors, leukemia, muscular dystrophy. So at least think of limbs. All right. Okay, so our first one of this was a 4-year-old who had a URI that started 8